My name is Christy Johnson, for those of you I have not met, and I'm the admin and founder of the DSP Cardiomyopathy Support Group, which was started in 2021 with the help of all of the organizations that are on this first slide. So SADS, Johns Hopkins, and the DCM Foundation. We are now at about 484 members in our Facebook group. And I think of it more than just a Facebook group. It's a community of desmoplakin cardiomyopathy patients and families that really care a lot about the condition and finding a cure. All right, in addition to managing our group, I also volunteer with the SADS Foundation as the chair of the Board of Trustees and the leader of the ARVC Steering Committee. I also work to try to create other groups like ours with the Genetic Cardiomyopathy Awareness Consortium. And I want to sincerely thank Marcia and Allie. I don't know if Allie's on, but if she is, you can wave too, Allie. And the whole SADS team for helping us host this event tonight. It's just been so fun and wonderful to work with them on it. So first and foremost, for this presentation, I'm a DSP cardiomyopathy patient, and my journey started in 2020 when I went into sustained VT out of what seemed to me to be the clear blue sky. I was in a lot of sadness and grief. It was a large family problem, we found out, but it wasn't until I reached Johns Hopkins, specifically Brittney Murray and Crystal Tishnell, who are both hopefully here, who really helped me get out of that blanket of confusion I was under after getting diagnosed. So thank you to them. A little emotional. So just some quick ground rules for tonight's webinar. Please keep yourself on mute throughout the presentation, but stay on video if you would like so our presenters can see you. If you have questions for Dr. Gasperetti and Brittney, please put them in the chat. And my wonderful co-conspirator for tonight's presentation, Andrea Gavin, will read them at the end of the presentation. So you can put them in the chat throughout the presentation if you want to, but we'll get to them probably toward the end. And just a reminder that Dr. Gasperetti has built his presentation around your questions that you've asked for the last several weeks. So we may not get to every single one of those questions in the chat. So I'm sorry if we don't. We'll try to get as many as we can, but I hope you got your questions in early, and Dr. Gasperetti and Brittney will get to those. All right. And before I introduce our speakers, I want to recognize and thank the patient organizations who not only support our group, but so many other patients like us. Next slide, please, Marcia. So the SADS Foundation. The SADS Foundation obviously is hosting this presentation, and they are focused on the arrhythmogenic side. So their mission to save the lives and support children, adults, and families affected by genetic heart conditions that predispose them to sudden death due to arrhythmias. Next slide, please, Marcia. The DCM Foundation, their mission is to provide hope and support to DCM patients and families with dilated cardiomyopathy through education, research, and advocacy. And you can see where to visit them as well. And I just, again, wanted to thank both these organizations. I feel so strongly about them that I volunteer for both of them. I feel very strongly too about the work that needs to be done on both sides of our disease, right? Both there's a heart failure side, there's an arrhythmia side. Some people aren't affected by all of them, but these two organizations are really, really good and have supported not only our organization, but my personal journey as well. So thank you both so much. Next slide, please. Now we're finally going to get to the meat of our presenters here in our presentation. So we have Dr. Alessio Gasperetti here with us tonight. He was born and raised in Milan, Italy, and graduated from the University of Milan Medical School. He completed a postdoc fellowship at the University of Zurich and is following with a 3-year ARV fellowship at Johns Hopkins University with Dr. Hugh Hawkins. You can read his research interests on the last bullet, but I just would like to say he is so impressive. If you've ever seen him speak at the ARVC conference that they have, that Johns Hopkins hosts usually in April, sometimes different times, but their annual conference, he's spoken a few times now and is such an impressive speaker and is very passionate about desmoplakin cardiomyopathy. And that's why he's here tonight with us. So we're thrilled to hear him speak. But before we do that, I want to briefly introduce Brittney. Next slide, please. So Brittney Murray, she already knows she has a piece of my heart for helping me. And she graduated from the University of Michigan, the Good Clinical Practice Program. She's a certified genetic counselor in cardiogenetics, so having that specialty in cardio. And then she's worked with Johns Hopkins. I can't remember how many years. I should have asked you, Brittney, but for a very long time, older than she actually looks, or longer than she looks age-wise. Let's just say that. And she is such at the heart of that program, along with Crystal and some of the other docs, of course. And she's the past chair of the National Society of Genetic Counselors in the Cardiac Special Interest Group. And she's extremely active in research, and again, knows so much about our condition. She's really passionate also about access to genetic counselors, which I'm sure a lot of you know is so, so important in our condition as well. So with that, thank you for joining. We really appreciate it. I'm going to turn it over to you, Alessio.
Okay, let's see if I can share. Do you happen to see the PowerPoint?
Yes, we see it.
Phenomenal. Well, first of all, Christy, thank you so much for the presentation, and to you, to Marcia, to Andrea for organizing this. I think it's phenomenal. As you know, desmoplakin is one of it's very close to my heart. I had the good luck to join the RVC program at this point around 6.5 years ago, and very early during my postdoc there, I bumped into Brittney and Crystal that have probably heard me ramble at this point for longer than they wanted. And very early on, there was a lot of interest in start looking at cardiomyopathies in a sort of a gene-specific way, just to make sure that each gene gets the clinical characterization that it deserves, and all those patients get some sort of what we now call tailored therapy in order to make sure that each patient is really being looked in an individualized way. And really, vast majority of my research effort during those years and during the past few years has been dedicated to characterizing DSP cardiomyopathy. And so, without further ado, uh, what's desmoplakin? Most of the people that are in this room are probably affected to some degree by this, either being part of a family or being a patient themselves. So, desmoplakin is a desmosomal gene encoding for one of the many proteins within the desmosome, which is basically the glue holding our heart together and making sure that the heart beats in a regular way and in a very well coordinated way. And now, unfortunately, we've learned over time that pathogenic variants in DSP genes are associated with very aggressive forms of cardiomyopathy. We used to call this left side arrhythmogenic cardiomyopathy, but over the past few years, we have seen that DSP has such characteristic features that this is now a disease per se, and it's called desmoplakin cardiomyopathy. So when I started giving a few of the desmoplakin talks, I always started saying why, asking myself why addressing DSP matters. And from 2022 or 2021 even, my answer used to be, DSP cardiomyopathy has a very distinct disease phenotype that is more frequently left-sided compared to all the other cardiomyopathy that we see within the arrhythmogenic spectrum. It's very interesting that we see a lot of female patients, which is very uncommon. All our other cardiomyopathy tend to be more predominant and more aggressive in male patients, which does not seem the case in desmoplakin. And generally, desmoplakin is very strongly associated with the occurrence of myocarditis episodes. We also said we don't have a lot of data about desmoplakin. Most of our data, RVC and other cardiomyopathy, comes from other forms, but that's why it's really important to talk about desmoplakin. My answer over the years has significantly changed. The reason why addressing DSP matters, and this is my 2025 answer, is because it's common. Over the years, we have seen more and more desmoplakin patient coming to us, to the point that right now it's the second most commonly referred gene to our program for evaluation. And I have very little doubt that over the next few years will actually become the most commonly referred gene to our program. It is one of the most rapidly growing orphan rare disease being recognized. And this is mostly thanks to the incredible job in raising awareness that, SADS and many of the other organizations have done, to the point that now we're seeing a lot of patients that for many, many years were diagnosed as chronic myocarditis actually getting genetic testing and finally being recognized as DSP cardiomyopathy, which carries very different prognosis and requires such a different management. And finally, it's also important to recognize that the scientific community has moved significantly with new consensus statements coming in the US from the American College of Cardiology for myocarditis and new guidelines coming out from the ESC this summer that really pointed out how DSP is something sort of unique. But another very important reason why talking about DSP matters even more these days is that we may be moving towards having actionable therapies, meaning that there is something that we can do for DSP patients that we have proved working, or we have reasonable data suggesting that it may be working in DSP patients that does not seem to work in other cardiomyopathy. So it is important to address this because it's common and because there is something we may be able to do about this. So just to lay out the lay of the land and get a sense of where we're moving, last year in Zurich there was a big meeting from the entire scientific community that basically all the greatest opinion leader across the world gathered, talking about how we should start addressing cardiomyopathy, gene-specific cardiomyopathy. And the general consensus is that moving forward, we will be moving in a gene-specific way. And gene-specific diagnostic criteria for all cardiomyopathies, including the DSP cardiomyopathy, are expected to come out at some point during the next 12 months. This just to say that there is a lot coming, and a lot of the feeling of being left out by the diagnostic criteria or being unable to receive a proper diagnosis, this will change very soon. And again, this is something I always like to point out. When I started in 2021, the Johns Hopkins DSP cohort was less than 70 patients. And over the years, it almost doubled. And so whenever someone feels lonely, feels left out, just remember, you're not alone. You're part of a big community. We are putting together data to give you answers. It may be slower than what many of you hope for, but we're working on this. And the other part is, if we take a look at what gets published in PubMed, which is our repository for all the studies that are published by the scientific community, there are currently 437 studies mentioning DSP cardiomyopathy, and more than 200 have been done in the relatively recent past. So you're not forgotten. We're moving forward, and hopefully we're going to get more and more data. So one of the big initiatives that we jump-started when I started working at Hopkins was the Desperados Network, which is basically a gene-specific effort started in November 2020 at a worldwide level with the idea of gathering as many clinical data as possible from as many DSP patients as possible across the world to finally be able to have a large sample of patients to clinically describe this very aggressive disease. And again, this is a big shout out to Brittney that has core labbed every single one of all the variants in this large registry. We have been able to really gather a large sample, including probants, family members, adults, children, young active adults, sportsmen, people that do not practice any sports, to really have a full representation of all the potential situation and phenotypes in order to gather enough data to give you all answers. And so I always like to provide some network updates every time I give a talk, just to give a sense of how everything is evolving. Around a year ago, a little 18 months ago, we had around 23 centers with around 1,000 patients. We're currently doubled the amount of centers. We have 46 centers, and I think at the last count, I was actually closer to 1,700 patients involved. So it's really a significant number of patients that are coming together. And to hear that there are almost 500 people in the Facebook group, it really means that we are getting closer and closer to have a very strong community. And the part that is always nice to see, even from my perspective as a physician, but it's very nice to see how engaged the community is and how really they're trying to take a matter in their own hands to be really part of something greater than a disease. So, a quick recap of what we've done and what we know regarding this disease. This is a study that we published earlier this year. It's been around for a while. It took a peer review a little longer than 12 months to get it accepted. But basically, this study, we used data from around 800 patients to really characterize what the DSP cardiomyopathy looks like. And this is really important because I bet that across the many people in the room today, many of you have heard very different terms in very different time point. Many people have come to us as part of the ARVC community, meaning a more arrhythmogenic disease. But as Christy was mentioned, there is not just the arrhythmic part or the arrhythmic component is this important disease. There is also a very important heart failure component. So many patients present with what's called DCM, dilated cardiomyopathy, which is predominantly a squeezing problem, the heart not squeezing as strongly as it should. But many, many, many more always present with something that we called non-dilated left ventricular cardiomyopathy, meaning a form of cardiomyopathy that is not dilated, is not arrhythmic. We don't really know what it is, but it seems very characteristic for DSP, and is generally characterized by those recurrent episodes of chest pain, of myocarditis, and a lot of scar in the heart that is generally defined through MRIs, through something called LGE, late gadolinium enhancement. Now, the big effort that we had as a community, and this was co-led by my colleague and close friend, Dr. Carrick, was the DSP risk stratification, the risk stratification tool, the DSP risk calculator, which is basically an algorithm that allows physicians everywhere to plot in the clinical characteristic of any patient with a DSP variant and using some of the data that we gathered allows to basically give an estimate of what the arrhythmic risk is over the next 5 years. The reason to use this calculator is the first time we see a DSP patient, one of the things we always fear is to miss an arrhythmia in the months, years to come. And considering that many of those ventricular arrhythmias are generally very fast and can be life-threatening, it is really important to know how high the arrhythmic risk of a patient is because we may need to implant a defibrillator. And clearly, defibrillators are not fun for us to place or for a patient to receive because they're an invasive procedure, can really change the body perception. And again, it's a foreign body under your skin. So it's not a light decision to take. It's a decision that requires a lot of discussion. And being able to say, hey, over the next 5 years, you have a 5% chance of getting an arrhythmia or having a 70% chance of arrhythmia clearly can steer the decision in one direction or the other. And the end game for us is just to be able to serve the patient the best we can, to provide them with all the information so that we can have a conversation and give the patient all the power of the decision. And so being able to estimate the risk of arrhythmias was really one of our main goals. We're currently in the process of validating this with a second cohort. There were around 450 patients in the first cohort. A similar size cohort is currently being submitted for validation. It's not published yet, but the data seems to hold pretty well. So we were very happy with the performance of this risk tool. And again, the idea is to identify those that are those red flags that we should be aware every time that we evaluate a patient with desmoplakin. Female sex, as I've mentioned previously, it's certainly a risk factor in this patient population. The presence of shorter run of tachycardia, something called non-sustained ventricular tachycardia, is another important risk factor. And then there are three risk factors that are equally important. The amount of extra beats, the PVCs that are in 24 hours. That's the reason why many patients undergo Holter monitors or Zio patches to get a sense of how many extra beats they have. The higher the number, generally the higher the risk of arrhythmias. And then we do morphological assessment. It's not just an electrical problem, it's also a squeezing problem. So ejection fraction on the left side being less than 50% and having an RV dysfunction, moderate to severe, are pretty significant risk factors that should be identified and discussed. But so, a few topics for the night. I've been kindly given by Christy and Andrea some of the questions that seems to have the highest interest for the crowd tonight, and so I started gathering in three main topics. One main topic is certainly exercise, and we're going to go through a few updates. Immunosuppression has been moving forward quite fast over the last 12 months, I would say. And finally, I will briefly give a couple of indication over genetics and variant-specific data. I'm going to ask Brittney to talk a little bit about family screening because I think it's a very important topic that should always be mentioned whenever we give these kind of talks. And so just to jump right into it, I think that many people that are, scouting the internet to get a sense of what's going on and what new studies are coming out that are interested in exercise and desmoplakin has probably seen those two main studies addressing exactly this topic. The first study has been published last year from our group at Hopkins. The first author is Dr. Jacobson. We generally observed the outcome. We observed the outcome around 100 patients with desmoplakin pathogenic or likely pathogenic variant. Two-thirds of those patients were athletes. The remaining third were not. And the second study, instead, it's a very recent study that was published around, I would say, a month ago from a group in France, from Dr. Jean et al., with 85 patients being enrolled. And down there, you can see the two main papers. And I think that it's important to discuss this because the conclusion of the two studies apparently are very different, but I think that there is a way to reconcile the different findings and to get a sort of a unifying theory across this. And I really want to talk through this because I feel very strongly about my opinion on this, and I think that the data supports it. So to briefly go into this, it's really important to discuss this topic because our findings at the Johns Hopkins really supported exercise restriction in patients with desmoplakin cardiomyopathy, while the data coming out of France sort of showed no difference in outcomes between desmoplakin patients that were exercising versus those that were not exercising, sort of suggesting that exercise could kind of be tolerated in this patient population. I think there are a few reasons why that is not the case, and over the next couple of slides, I'll try to make my case for exercise restriction in desmoplakin. The main reason why I think that our patient population at Hopkins really showed how detrimental sport is for patients with desmoplakin is that a lot of our patients were probans, meaning patients that were diagnosed as the first member of a family, and that we know that those are the patients at the highest risk because those are the patients that present. Having a lot of family members in a study cohort generally tends to dilute the what we call the event rate, meaning family members are generally less affected because they either diagnosed early and so they haven't accrued enough time with disease to develop any sort of adverse events, or just because their presentation being delayed means that they weren't so sick to look for a doctor to begin with. And so the main difference between our cohorts is that around 50% of our cohort was composed by probans, while the French cohort only had a third of that being probans. The other part is that our patients were younger, meaning that we know that in arrhythmogenic cardiomyopathy, age is generally associated in a reverse wave to risk, meaning that younger patients are at a much higher risk than elderly patients, with most of the arrhythmic events happening in the second or third decade of life. So my concern with the study coming out of France is that their cohort was at low risk to begin with, and so not the proper cohort where to check for the impact of exercise. But to even build up on this, is our colleagues in France only addressed the impact on exercise at the time of first clinical presentation, while we looked at the impact of exercise at follow-up as well. So the amount of the events that were present in the French cohort were very low. And this is sort of a little bit of calculus and statistics, but if there are very few events in a study cohort, it is very difficult to figure out if something is causing those events or not, because those events are rare to begin with. And that's why in a rare disease with rare events, it's difficult to run research and run studies. We decided to follow up patients for up to 4 years to make sure that we properly had the power, the statistical power, to get a final answer regarding sport. And so we did not just use events of presentation, but we also had data from events of follow-up, which are substantial, and they almost tripled the amount of the events that we were able to gather. And so I really think that we were better equipped to address this question. But another important point, this is also highlighted by the editorial comment that an Italian group published alongside our the French study and JACC electrophysiology, is that they really looked this at a single time point at diagnosis, completely forgetting about disease progression. So kind of the data that was presented was interesting because certainly added value to our community presenting data on a cardiomyopathy that has not been described extensively. This is only the second study addressing the topic at all. But I think that their findings of exercise not causing harm in patients with desmoplakin should really be taken with a big grain of salt. And I don't think that our very cautious exercise restriction approach should be overturned. An additional point that I would like to make is that between exercise and desmoplakin, there is not a direct link, but there is a link nonetheless. And by this, I mean that whenever we talk about exercise in arrhythmogenic cardiomyopathy, we generally refer to plakophilin 2, which is sort of the poster child for this disease. And this is the gene that has been studied the most over the last 25 years. And it really is a gene that causes mostly a right-sided, right-dominant arrhythmogenic cardiomyopathy. The effect of exercise is very clear. The vast majority of those patients have increased strain on the right ventricle because they are doing endurance exercise. Their ventricle fails more rapidly, and they go and they experience ventricular arrhythmias and heart failure. Around 20% of patients with PKP2 have their first arrhythmic event during physical exercise. And it's very easy to prove a direct link between exercise and adverse outcome in plakophilin 2. This is not exactly the same thing for desmoplakin, because being this mostly a left-sided disorder, the impact of exercise is not directly on ventricular arrhythmias and heart failure. But our data seems to suggest that this is mediated through actually myocarditis, which is an additional analysis that our colleagues from France did not run, and I would be very interested in having more data to confirm what we found in our cohort. Because at the first time when we ran our numbers, we did not see a direct link between exercise and outcomes in desmoplakin. But when we accounted for those myocarditis events, the entire picture changed, because what we saw is that the exercise seems to put excessive strain on the desmoplakin heart, causing more bouts of inflammation that, as we know, are downstream associated with worse ventricular arrhythmias and heart failure. That's why when I say there is not a direct link, this does not mean that there is no link at all. exercise cause myocarditis, and myocarditis seems to downstream cause worse outcomes in patients with desmoplakin. And this brings us to probably the main topic of the night, which is myocarditis. I've mentioned this term multiple times. Myocarditis is what we call inflammation of the heart. There is a million ways through which myocarditis can present: arrhythmias, bradycardia, tachycardia, the heart beating fast, the heart beating slow. But the classic presentation is chest pain, palpitation, and shortness of breath out of the blue. Many patients tend to associate those episodes with nausea, with vomit, with feeling really weak. And this is very well documented, and it's very common for patients with desmoplakin. It's normally a clinical diagnosis, meaning if I know that a patient has desmoplakin and comes with those symptoms, the diagnosis is basically made. But we really use MRI as a final diagnostic tool to visualize two things: edema, meaning that there is fluid around the heart because there is inflammation and there is swelling, and late gadolinium enhancement, meaning that the inflammation is causing scar and fibrosis in the heart. Now, in the Desperados network, we have, as mentioned, around 1,700 patients that we have a follow-up of around 6 years for those patients. We do see an incidence of around 3% per year of follow-up, which means that the vast majority of desmoplakin patients will probably end up having at least one of those episodes during their lifetime. Those episodes seems to cluster, with many patients having multiple, 5, 6, 7. I think that the personal record I've seen is 17, but across the Desperados network, I think that the highest number is in the 20s. And they can really happen at any age. They seem to be more common before the fourth decade of life. Children and young adults are very prone to those, both at rest and exercise, and interestingly are equally common in the two sexes. So while we see female having a worst overall prognosis, the amount of myocarditis episodes we're seeing does not seem to be impacted by sex very much. Why do we care is the other question. Clearly, symptoms are never fun to have. But if this were just a cold, if this were just some soreness, that I can tell my patient, hey, don't worry about it. It's gonna go away in 2 weeks. It's not really important. I'll be very happy. But unfortunately, that's not the case. We have seen that myocarditis represents a significant time point in the natural history of desmoplakin cardiomyopathy, meaning that there is a pre and there is a post of those events, with the disease progression and the prognosis getting worse after the occurrence of myocarditis. We have seen that after the first episode of myocarditis, the overall arrhythmic risk goes up around 2.5 times, and the risk of heart failure goes up around 5 times. So this is really important for us to know. It's important for the patient to know, because the patient needs to know that those episodes should not be forgotten. Something to mention to your doctor, is something to seek care for, because a patient that does not have an ICD that gets 4 myocarditis in a row is a patient that, when comes to me and see me in clinic, we're going to have a very different conversation compared to a different patient that has had no myocarditis at all. Those episodes really change the risk profile of a patient, and are really important to be tracked, and we should be really aware of their impact. And this is some very recent data. I think it went up on the website probably 3 days ago. So this one is probably our last effort as a Desperados network. We really tried to address the prognostic role of those myocarditis events, and we tried to see what we can do about it. The graph on the right is sort of something that we have postulated for years, but we were never able to prove until this manuscript, which is the idea that someone having a myocarditis has not exactly the same risk profile of someone that has had 20. The general idea is that unfortunately there is a dose response between myocarditis and overall events, with the more myocarditis tend to equate with a higher risk down the line. The part that, however, got me the most excited about this manuscript is the possibility of starting doing something about this. For a couple of years, at least, in the DSP community, in the ACM community in general, we have talked extensively about the possibility of using immunosuppressant medication to try to modulate those myocarditis episodes. And really, it took quite some effort to put together 42 centers to get enough patients to prove it. But what we're seeing is that that increased risk that we see after a myocarditis event can potentially be negated and stopped by the usage of immunosuppressive medication. It's important to note that this is retrospective data, so this is not the full story and is not has not the same level of evidence that we have for many other cardiac conditions, just because unfortunately it's a rare disease and it's difficult to build studies that are bulletproof in terms of statistical interpretation. But when we saw those results, we were all pretty convinced that there is something in here. And there were going to be 3 slides with very similar graph. But what those graphs are showing is that treating myocarditis with immunosuppression, the red line on the left, or with colchicine or with aspirin, the yellow line, or not treating at all, the blue line, end up with very different results down the line. In those graphs, the higher the line remains, the better it is for patient, because it means that a lower amount of patients are experiencing arrhythmias, new myocarditis, or heart failure. And as you can clearly see, the red line, both on the left, which is a combination of myocarditis, heart failure, and arrhythmias, and on the right, which is instead ventricular arrhythmias alone, the red line, which is the line representing the patient treated with immunosuppression at the time of myocarditis, seems to be significantly different from the other. Additional data here shows that this does not prevent future myocarditis. Most likely, those episodes of inflammation are caused by the underlying genetic background that is unfortunately broken, and the gene presents this variant that is not coding for the right protein, is the reason why patients end up having myocarditis. But while we cannot stop the myocarditis from happening, what we can do is stopping the bad downstream effects. And the most important part is that if we take a look at the black line and the red line in those 2 graphs, the black line represents the line of all those desmoplakin patients that has never had a myocarditis in their clinical history. This data seems to point towards a complete negation of the myocarditis effect, meaning that someone having a myocarditis receiving immunosuppression has the same risk profile of someone that has never had the myocarditis, which, if this were to be validated in larger studies and prospective studies, will really mean that we have something that we can offer and can really change the natural history of this disease. To be a little bit more clear about what I mean when I say immunosuppression, there are probably 4 big groups of medication that fall in these buckets that have been used in desmoplakin. 80% of all the patients that have been treated with immunosuppression have received glucocorticoids, something on the steroid family, something that could be prednisone, methylprednisolone, methylprednisone, all different formulation of steroids that are very much a broad spectrum anti-inflammatory medication that generally works well, but comes with significant side effects, weight gain, increase in sugar levels, euphoria, confusion. So they work well, but they have significant side effects. Then I would say that the second most commonly used medication are mycophenolate and azathioprine. Those are more targeted medications. They have less side effects, but they require significant monitoring because they can cause blood problems. They can cause, and especially in female patients, unfortunately, they're teratogenic. So anyone interested in becoming pregnant cannot be on mycophenolate on the long run. And then there is miscellanea of various immunosuppressive medication, going from immunomodulators like anakinra to IVIG to there is a significant amount of drugs out there that, however, haven't reliably been used in a way that it's easy for me to gather into a group. And it's important to know that not all patients will respond the same way to the medications. And that's why sometimes we try to we try one regimen. If the regimen doesn't work, we can try to switch some of those medication. It's not really just science, it's more of a craft. It's trying to figure out what the patient tolerate best. And as I mentioned, we don't know if this is the true final answer to the question. So I don't want to put out the message that this is the absolute truth. I think that this data is very encouraging. And I think that since we came out with this experience, more and more colleagues across the world are using immunosuppression, but we don't yet know what's the right regimen, how long to continue the regimen, and how intense this regimen should be. And I really think that over the next year or so, we're probably going to gather a few more data on this topic. As I mentioned, the main goal of this is to try to dampen inflammatory response and hot phases to make sure that there is slowing of the cardiomyopathy caused by this hot phases, to control symptoms as well. Very often, chest pain, recurrent chest pain is something that is reported by many patients with DSP cardiomyopathy. And we hope that several of those medications can really help with controlling those symptoms. And again, the ultimate goal will be to prevent disease progression. But as I mentioned, the jury is still out for all three topics. For some patients, they work really well and they seem to make a difference. Unfortunately, for others, they keep having myocarditis and they keep having symptoms through several lines of immunosuppression. So I don't think we have the final answer, although we certainly hope that there is something in here to offer to all our patients. As I mentioned, most of this data is retrospective, so it will need prospective validation. We are currently collaborating with several centers to make sure that every time we start immunosuppression in a patient with DSP, we sort of gather those data, both in the US and in Europe and in Australia and in Asia, so that we are not excluding anyone from our data collection. We almost never use non-steroid medication alone. Most of the data that we have is for steroids or steroid plus regimens, meaning that generally it's a combination of steroid plus mycophenolate, steroid plus azathioprine, and they remain on for couple of months bare minimum, sometimes shorter course if the dose is very high. But steroids are sort of the hallmark of our immunosuppression strategy for now. And a part that I think it's really important, I believe I had a conversation with Dr. Lakdawala in the past regarding this. I think we all agree that NSAIDs, and with NSAIDs, ibuprofen, aspirin, and colchicine, they are not immunosuppression. Those are medication that can help with symptoms. They are medication that work very well for pericarditis, but they don't seem to do much for myocarditis. And all the data that we have really point towards those medications not really changing much in patients with desmoplakin cardiomyopathy, to the point that if they help with symptoms, great, but that those alone will not stop me from considering immunosuppression, because I think that immunosuppression and those two medications have really different roles in taking care of patients with DSP cardiomyopathy. Few more words about genetics and variants specifically. We currently do not have individual variant analysis or data, just because there are so many different variants that it's very difficult to know what the clinical outcome associated with a specific variant is. We know the variant location matter, and variants are classified in three main groups. NMD competent variants seems to be the one that we really try to set apart from others. This is data coming out of a large collaboration in the Netherlands and Australia with some of our colleagues from Stanford. Really, it's important to identify NMD competent variants because they seem to do worse from an arrhythmic perspective. So this is something that I've asked Brittney a million times to evaluate for all our patients, because every time we get a new patient in the registry, it is really important to know in what of those buckets the patient falls, because they have a different risk profile because of this. And a point that I would like to make, just because we're talking about genetics, is that just having a DSP variant alone, while having no phenotype, for other genes, we're saying that someone with a gene positive and a phenotype negative, all in all, they're doing well, and it's not a big problem. For DSP, we're seeing a higher penetrance than in many other genes, meaning that having the variants alone, although the number reported in that black circle are much, much lower than all the numbers reported for any other phenotype, those numbers are still not low overall. 0.5% per year of ventricular arrhythmias chance in someone that has a DSP variant and no phenotype is definitely not nothing, especially because it builds up quickly. Over 10 years is 5% if the phenotype is still absent. 3% of our failure over 10 years is several fold higher than the general population. So that's one of the reasons why I'm very happy when I don't see a phenotype, because it means that the DSP profile risk is lower, but lower does not mean zero. And just because we're saying lower doesn't mean we have to forget about those patients. And that's one of the main reasons why I strongly recommend family screening. And just to be able to know who's affected within the family is really important, because following up those patients longitudinally, it's really part of our strategy for making sure that all the patients are properly taken care of. And so before letting Brittney give me a couple of pearls on how to pursue family screening, I just wanted to share very quickly what are the main questions that we'll probably be tackling over the next 12 months or so. I have my mental appointment every year is the family meeting at the Johns Hopkins that we do in April. As Christy was mentioning, I generally plan year by year using those as my benchmark. And so the main questions that we have, sort of, as I mentioned, for arrhythmic risk stratification, we're currently working at the validation of our risk calculator. My hope is to have the manuscript published by next year, so that everyone feels very comfortable using this across the globe. We're trying to collect disease progression and longitudinal data. This is sort of our weakness right now as a registry, just because it was important to start somewhere, and we started from first assessment. But it will be very important to know how quickly this disease progression, what to expect, not just over 3 years or 5 years, but maybe over 10 or 20. Clearly, having started this effort in 2022, it's difficult to have 20 years of follow-up gathered, but we will try, and we will be starting in a very systematic way to collect more and more data, to have data over a longer period of time. And again, we want to start looking at those special DSP population, sort of our pediatric cohort. We want to take a look at what this disease looks like in children, and what it looks like in family members, because we know that they are at a higher risk in DSP than other genes, but we don't exactly know what higher means in the big scheme of things. And finally, as I mentioned, I think that it will be very important to figure out what immunosuppression and what immunomodulation regimen to use and for how long. Brittney, anything you have on family screening? The floor is yours.
Yeah, so I think there's lots I could say on family screening and the genetic testing process and all of that. I think the most important thing that we can do is make sure that there's cascade testing of the variant through your family. There's a lot of, we know drama sometimes within a family that goes into cascade testing and making sure you know the variant. But the only way that we can protect you is if we know that you are at risk. And so it's really, really important that family screening goes out generations. The saddest thing that I have to do is when we connect the dots about, second cousins twice removed that never really got the memo about things, and then there's another death in the family. But the important thing is that we can prevent bad outcomes in DSP cardiomyopathy, but only if we know about it. So first and most important is genetic testing to know who we need to watch. I know Alessio said a lot of really scary things about no phenotype, you're still at risk and things like that. But I'll tell you clinically, no phenotype is something that is very different from a research definition to what Dr. Hawkins and I see in clinic in terms of no phenotype. Truly zero, absolutely no phenotype. We really have never seen in our registry any dangerous arrhythmias in those population. There are certainly people who have subtle things that don't meet any sort of research definition that we worry about, or even have normal MRIs that we act on. But I want to encourage you and reassure you that screening is protective. And we can catch DSP cardiomyopathy before it shows up, before it has bad outcomes. And that in our recommendations for most patients, so this is most patients who have one mutation in your family that tracks with your family. So there's a whole bunch of caveats about complicated things that I see. But generally, for most patients who have one mutation, which is most of you here, we start our screening at ages 8 to 10 because we really, in the international community, we have not seen DSP cardiomyopathy with one mutation showing up at younger than that ages. So we start our screening at ages 8 to 10 with ECG Holter echo every couple of years. But we're really hoping as soon as the child is kind of psychologically ready to do it without sedation, to add in an MRI rather than echo later, because we know seeing that scar is actually really, really important. And so we like to do the MRIs close to 10, 11, 12 as we can. But we know I have 2 boys myself. Some kids are just really not ready for an MRI that young, and that's okay. We have other ways to look for them. And then we watch you every 1 to 2 years, at least through teenage years, 20s, 30s, 40s. And after that, if things really have been normal, we start to taper things off. But this is an age-related penetrant disease. It can show up over time. So we really do need to keep an eye on you. But you can be reassured that keeping an eye on you, we can catch things and mitigate things. And our family members do indeed tend to do better with early recognition and management. So I'll end on that optimistic note.
Thank you, Brittney. Just to close up, again, just those few sentences are one of the reasons why Brittney is such an important and essential member of our DSP program. Crystal, equally important for us. Many of the patients know her for her kindness and for her response to all the clinical questions that are out there. Those are contexts. Dr. Calkins has been a huge mentor for all of us. He started the ARVC program and our cardiogenomics program for arrhythmogenic cardiomyopathy. So nothing of what you've seen today would have been able to exist without his supervision and without the help of many, many other people. Those are our contexts. I know that some people asked Christy and Andrea how to potentially support the program and the research, so we'll have the QR code for that. More than happy to take questions.
Thank you so much. That was super, super informative. And thank you for sharing all the data, and really excited to see what's coming up in the next year and all the efforts. So I guess quickly, I mean, exercise is always top of mind, but Jeffrey is asking, what degree of exercise restriction do you recommend? Would an approach of keeping exercise in zone 2 be accessible? And he is wondering about exercise restrictions for phenotype negative patients as well as for phenotype positive patients.
It's a very good question. And we hope there is a very huge push, not just in DSP, but across arrhythmogenic cardiomyopathy, to get more granular data on how much exercise is actually detrimental. The current guidelines per the American Heart Association are to have light endurance exercise for around 30 minutes around 3 times a week, which may mean very different thing for very different people. I'm sort of a couch potato, so light exercise for me may be what some other people don't even consider exercising, and it's difficult to say. I don't think that there is a heart rate that we should be using as a goal because the detrimental effect of exercise is sort of independent from the heart rate. I would recommend, especially for patients that enjoy non-endurance form of exercise, mixed exercise, or strength exercise. It seems that all those forms of exercise are less damaging than classical endurance exercise. I think, swimming, rowing, cycling, those are all big no-nos from my perspective. I really try to counsel patients to look for a different sport if they can. Triathlon, but someone that likes to go to the gym and do some mild treadmill for 10 minutes and then some weightlifting, I think that there is nothing bad with that. I do not have exactly access to granular data. I know that in Europe, both in Germany and in Switzerland, there are a couple of research studies currently being run regarding an exact association between dose and response in exercise, with different sports being tested at different intensity to try to be able to sort of quantify the damage associated with exercise. The answer will not be gene specific to begin with, just because it's unfortunately very difficult to do so. I think we're going to get ACM umbrella recommendation first, and then we'll try to get a little more data on DSP specific level.
Yeah, what Dr. Calkins and I generally talk about in clinic is it's a long conversation about not all exercise is created equal. And so, on one end, you shouldn't be restricted completely. And we want you to be active, and we want you to be minimizing your other cardiovascular risk factors and all of those things. However, that's generally for most of our patients the that type of activity that they want to do. The worst things that we really see are the endurance sports, as Alessio mentioned. And it's really about moderating your intensity and duration. So how intensely are you exercising and for how long? Right now, in terms of phenotype negative patients, we don't have the strength of data that we have in PKP2 to suggest that not exercising would avoid disease at all. And so that has been complicated in terms of every family making a little bit of their own decision on what you do with your family members who don't have disease yet in terms of their exercise. It's not that we have data to say that it's fine. We just don't have the strength of data that we have in PKP2 showing that you can truly avoid disease at all if you restrict your exercise.
And there are a couple of related questions on exercise stress tests. Christy asked, what's your take on the exercise stress tests for a DSP patient with a history of arrhythmia? Is it risky? And on a related note, Graham asked if a stress ECG is suggested by a cardiologist. What is the risk-benefit analysis?
I think that there is a very different approach to stress EKG in the States and in Europe. I know that our European colleagues tend to use exercise EKG or stress EKG to risk stratify patients way more than we do in the United States. I honestly think that is, of all the many diagnostic tests that we have, is the one on which we have the least amount of data. I would certainly say if a DSP patient is to undergo a stress test, my recommendation will be to have a physician in the room all the time with a defibrillator readily available. I don't think it's an absolute contraindication. I also don't think that there is a lot of data to suggest that there is prognostic value or that will significantly change my decision making in terms of risk stratification and device placement. But it is one of those topics where there is not a lot of consensus, and I think that different physicians may practice differently just because there is no uniform guidelines. So it's a little bit of a wishy-washy answer, but I don't believe we do that many at Hopkins at all, or in the States.
Yeah. I will just throw out there, there's different types of stress tests. So Alessio was talking about a stress test kind of for diagnostic predictive reasons, in terms of a stress ECG for risk stratification. I will say, as Christy mentioned, heart failure is a big deal in our DSP cardiomyopathy patients. So a metabolic stress test or VO2 max test, once you have a diagnosis and you have an ICD, our heart failure physician, Dr. Paul Scheel, actually put together a series suggesting and providing data that it is safe. And that is something that is very, very helpful in the heart failure assessment and workup. So that type of stress test is extremely, extremely useful. And it's a little bit different than what Alessio was talking about. The type
Absolutely.
of stress test where you just run on a treadmill to try to see if you have VT.
Thank you. And Christina asked, is myocarditis always or nearly always symptomatic? And Christian, this is my question too. Also, if you don't have symptoms, I personally have never had a myocarditis symptom. How is it clinically diagnosed, and should we be tested regularly?
I think that the answer is no. We see several patients with DSP presenting into clinic with, increased in troponins, which is one of the biomarkers that are checked at several instances that are increased, and this could be a marker of a heart damage. So whenever someone has a myocarditis, the troponins is very high. Now, I think that it's important to distinguish between clinically significant myocarditis and clinically silent myocarditis. For research purposes, I know that someone has had a myocarditis if that myocarditis was symptomatic. So most of the data that we have pointing towards myocarditis being very important for risk stratification are probably derived from those clinically significant myocarditis. I think that MRI very often will show gadolinium progression over the years, and that is something that could be associated with sort of silent episodes of myocarditis. Our colleagues in Michigan, Dr. Helms, that I'm sure many in this group are familiar with, I was personally convinced that the presence of gadolinium in DSP is very often caused by silent episodes of myocarditis. I think it's really possible. One of the things that we're trying to do is to routinely collect troponins data at each visit, exactly to sort of screen for potential silent episodes. I don't have data to know if a silent episode has the exact same clinical value that a very active episodes. My gut feeling tells me no, but I think we need more data about that, and that's one of the reasons why we're trying to get those data pulled together.
And on a related note, Stephanie asked, aside from exercise stress, what are other causes contributing to increases in heart scar formation that are appearing on MRIs that we need to be aware and mindful of?
I couldn't think of many. I would say, as Brittney was mentioning, one of the recommendations that we have for all our patients is to control all your other risk factors. Blood pressure, avoid smoking, avoid excess alcohol consumption, avoid recreational drugs that are associated with cardiac damage. So it's really living a healthy life as much as possible, finding the right balance in the amount of exercise that is enough to protect your general cardiovascular health and not so much to cause damage. And unfortunately, it feels that there is, for the biggest risk factors, those myocarditis, there is not much that an individual patient can do because it's sort of a random event caused by the genes. But I think that trying our best to live a healthy life from all the other perspectives is really important.
And Kylie asked, this has come up a few times, if there's any research on pregnancy and DSP.
We're currently putting together our case series. I think that by the time of our next family meeting, we will have data. The data collection has been completed. We have collected data out of our collaborators in the Netherlands for sure, and I believe we have some data coming out of Norway as well. We just need to run the analysis. I don't have the final answer yet, but our hope is we're going to have more robust data by next family meeting or potentially one of the incoming conferences.
Great. Sorry, I'm just seeing, Jeffrey's asking, could you go into more detail about what makes an NMD competent and a non-NMD competent variant? How long this is very detailed, but maybe just briefly, how long of a truncation mutation would be competent?
Brittney,
Competent?
that's yours.
I don't think Alessio understands still, but it's okay because I don't understand inflammatory markers. But so basically, the moral of that story, it's a bunch of really fancy wording, but it has to do with a process called NMD, is nonsense mediated decay. And so it basically means when there is a typo in the instructions for the protein, how much of the protein is actually made or remaining? Is it completely gone? Is there part of it there? Is it only a small part that's missing? So this comes down to that where your variant is may be really important based on some preliminary evidence in terms of your arrhythmic risk stratification. So it has to do with where your typo is in the gene, which results into how much protein is actually made in your heart. And it's a very specific algorithm that I run for the team.
Gotcha. I'll just a couple more as we're going a little bit over time, but there's two related questions on troponin. Olivia asks, could a confirmed DSP patient have their troponin be at a higher baseline? And Jeffrey asks, if high sensitivity troponins are negative, would that case of myocarditis be clinically relevant?
So I start from the second one because it's probably easier. I think that the timing of the blood draw matters in that case. If there is a concern for myocarditis right now and the troponins come back negative, I think that my concern for active myocarditis is much, much lower. Now, if the troponin is negative now, I don't know if there was a myocarditis 6 months ago. So it's really a matter of how temporally associated the episode and the troponins are. It is, I think, well proven that at baseline, most patients with arrhythmogenic cardiomyopathy, not just DSP cardiomyopathy, have some degree of chronic release of troponins just because the heart is a little weaker, and probably those bouts of inflammation that we see tend to release a little bit of troponin. As we have not routinely collected at every single visit, it's difficult to say what is clinically significant in those patients. But I think that we are currently putting together enough data to answer that question. I would say that chronic elevation of troponin in DSP is sort to be expected. There are several case series out there, especially for patients that are very significant with chest pain. This is something that is sort of well documented.
Thank you. And Jeffrey is asking, are there any work on using biologics to suppress the immune system, such as anti-TNF antibodies?
So there are, and it's the long story short, it seems that there has been a lot of baseline work and translational studies in trying to determine what component of the inflammatory system is the one that is key for the inflammation that we see in DSP. It does not seem to be TNF mediated. It seems to be more IL-1 or IL-12 mediated. And that's the reason why those are the biologics that are currently being probably pursued the most. We don't have a ton of evidence. One of the medications that we're currently taking a look at is anakinra and rilonacept. Those are interleukin-1 receptor agonists. So it's really an IL-1 inhibitors that seems to be working decently. Yes, there will be a lot of interest in biologics. It's going to be important to find out the right one. The main reason for biologics is that generally their safety profile is much better tolerated than broad-spectrum immunosuppressant like prednisone. We just need to be very careful considering the potential cost and side effects that can be associated with those.
Thank you. And I'll end with the last question and then a request, I guess, just for our group. Christina asks, are there estimates as to how many people worldwide have DSP cardiomyopathy? And on a related note, I believe you said there are now 46 centers. And so if possible to follow up with a list of those centers, just so we can share for people around the world, just so they can go somewhere where someone knows what DSP is, that would be great for our group. But are there any estimates on how many people globally have DSP?
I don't have that.
So we actually have some new data on this out of in the US, for example. There's a bunch of evidence from the genetics community just trying to understand more about general population variation. And the UK has been way ahead of us in this, having this big database called the UK Biobank. But we have a database that was funded for a while that just published its first data just this month. It came out 2 weeks ago. And it's actually estimated that about 0.2 of the general population has an ARVC variant. And so the second most common of that is desmoplakin. So it's actually way more common than anyone ever thought it was. 0.2% of the general population is a huge number.
Wow. And I guess we're just about out of time. Is there anything, I guess, to share in closing? Thank you for promoting family screening and testing. I know there's been some questions about the importance of that, but I did see if anyone missed in the comments that Brittney mentioned that the ARVC seminar is scheduled for April 18th for anyone able to travel to Baltimore. But anything else to say in closing?
No, thank you for being here. A lot of what we do is only possible if patients are really engaged and work with us. And that's what makes our job, incredible. So thank you for being here.
Thank you so much. We really appreciate it. And yeah, and we'll stay in contact if there's other things patient groups can do. Brittney, Alessio, Crystal, you let us know, where we need to register, what we need to do to make things better for research. We appreciate it so much.
Absolutely.
Yeah.
Thank you, everybody.
I'll just throw one other plug out there as well. Of course, email Alessio or myself with questions. But of course, at any point, we'd be happy to see you as a patient at Hopkins, but you do not have to be a patient at Hopkins to have your data included in this research. You can email Crystal or I and enroll in the registry at any point. So we would be happy to have anyone contribute your data to this research.
Awesome. Thank you so much. And thank you, everybody who stayed late and listened to all the questions. We appreciate you. Thank you, Marcia. Thank you, Sads. Take care.
Good night.
You're
Good night.
welcome. Thanks for joining, everyone. Appreciate it.